Hi, this is Elliot Fishman, and we're on YouTube Live. I have a series of cases for you. This is our third Thursday, I guess, right, Lily? It's the cases, and here we go. I think I have 14 cases. This is a patient with right upper quadrant and back pain, and you see a large mass, which is very vascular. Could be pancreas, I guess, could be a liver mass, could be a big retroperitoneal mass. You can see on the coronal views and the 3D MIP, lots of vascularity. Again, could be liver, probably not pancreas, bad epicenter. Retroperitoneal mass, could be kidney. You don't see the kidneys here, but I'll tell you the kidneys are normal. And then you look at this image and you say it's invading the IVC. Now typically lesions that invade the IVC, we think about renal cell, adrenal cell, and hepatoma. I'll tell you it's none of those because you don't see a mass in any of those organs. What else could it be? Well, a retroperitoneal sarcoma can invade. There is one tumor that is a sarcoma in the retroperitoneum, but it's primary to the IVC. And so when you ask the answer here, you should include an IVC leiomyosarcoma. The rare tumors, they can be large. You can see extension into the IVC by tumors. I mentioned adrenal, liver, and renal, also stromal sarcomas from the uterus. But primary tumors of the IVC, classically IVC sarcoma. What a great case. Patient with back pain. There's a large mass by the right adrenal bed. I guess you couldn't say it wasn't the kidney here, but when I show you the next image, it's pushing on the kidney, so it's the adrenal. There's some vascularity at the edge of the lesions, and now you got a big vascular lesion, or partly vascular, and solid. Pheochromocytoma is the thought, but they're usually very vascular or they're cystic. I don't like pheo. Could be an ACC, primary adrenal cortical carcinoma. They're typically solid, though they can be cystic, can have lots of vascularity. That's a thought. It could be metastasis, hepatoma, melanoma, often mets are bilateral, but they can be unilateral. I worried about malignancy, and ACC was a big concern. This was resected. You know what this was? And this is what keeps all of us honest every day. It was an adrenal cortical adenoma. Adenomas, we think of under 4 cm, low density, washout. We think of all those things. But adenomas can be very large. They can be solid and have vascularity. What a wonderful example. And this patient was very lucky. Imagine going to surgery thinking you had a carcinoma and end up with an adenoma. You're cured. Back pain and elevated LFTs. You look at the liver, there's a low density zone here and maybe textural changes here. And then you say, what's going on? Look at this venous images. Now it's better seen. And it kind of looks like bands. It doesn't look like focal fat. It doesn't look like geographic changes related to tumor or vascular occlusion. There's something going on also in the pleural space. And if I look at it a little bit better, a little bit later, look at those bands. I'm seeing what looked like very sharp margins. When you see sharp margins, I don't care where it is, kidney, liver, lung, you got to think about something being done to the patient, and that being done typically is radiation therapy. And so what are we looking at here? And I'll show you another example, same patient. Look at these bands, look how sharply marginated they are. They're not just random, it's something was done. That's the hallmark of radiation therapy. And this patient had pleural masses, which were mesothelioma. Radiation of mesothelioma, radiation hepatitis. Just a beautiful, beautiful case. Really nicely showing you those bands. Do not make the mistake of calling that tumor or fatty liver or infarct or anything else. What a great case. Okay, another patient with back pain, hematuria and sickle cell disease. What do we see? The left kidney is larger. There's decreased attenuation. There's patchy enhancement. On the coronal view, you can see the diffuse changes in enhancement. When I see this, I'm thinking infarction, infection. Younger patients, particularly sickle cell, you can have infarcts or infection. Infarcts tend to be better defined. Infection, less well defined. Infection, also the kidney is larger. You see changes around the kidney. So what was the answer? Infection, acute pyelonephritis. Patients with sickle cell, pyelonephritis is not uncommon. So looking at that case, in this case, what's going on in the left kidney? it's non-contrast, but is there something going on? And surely the answer is yes with contrast. There's something infiltrating. Now you can say infection, infarction, but you also should maybe throw in, if you looked at the whole kidney, you would be able to do more. What about tumor? And when you look at the kidney, with PET, the kidney upper pole is hot. Could be infection, could be tumor. When you look at it in the coronal, you see it's the upper pole, but then you see something in the lung. So now I got something in the lung, something in the kidney. What am I dealing with? Is this lymphoma going to the lung? Is it renal cell going to the lung? Is it lung cancer going to the kidney? All are good thoughts. Well, guess what it was? It was metastatic squamous cell of the larynx to lung and kidney. So I like this case to show you the abnormal perfusion, the changes in the kidney. Think infarction, think infection, but also you got to be thinking tumor. Okay, back pain. Kidneys look okay. Look at the aorta. You see the calcification? There's soft tissue around the aorta on the non-contrast study, and it really shows well with the contrast. There's something infiltrating around the aorta and infiltrating toward the renal arteries. And when you look at the coronal, look at the extension around the aorta and the iliac vessels, in addition to around the aorta on the axials. And you show it very nicely on the cinematic where the aorta is narrowed. There's infiltration. And on the CT urograms, the patient had duplication of the right collecting system, but the ureters pinch medially. When you see something around the aorta and the ureters come medial, you got to think about retroperitoneal fibrosis. You could think about a vasculitis in this case. You could think about treated lymphoma, but the typical thing to think about is retroperitoneal fibrosis. And here are some of the images again. This was retroperitoneal fibrosis. What a great case. Okay, weight loss. I see nodules in the subcutaneous tissues. I see nodules in the spleen. I see nodules in the liver. I see lesions that are enhancing in part in muscle, gluteal muscles, iliopsoas muscles. I see nodules in the mesentery, nodules in the lung. I see the liver lesions. I see the pancreas lesions. I see peri and pararenal space involvement from the kidneys. We see things involving the bowel, and we see things involving the bladder. What are we dealing with? Well, when I see this, I got to think about lymphoma. Lymphoma can involve multiple organs. I got to think about metastasis, particularly melanoma. If you only had subcutaneous nodules, I'm thinking lymphoma, melanoma, breast cancer. But multiple nodules, perirenal space, pararenal space, pancreas, you got to think about renal cell, which we don't see. You got to think about lymphoma, that's a thought, but you got to think about melanoma. And this patient had melanoma metastasizing everywhere. Just a really nice example. Okay, acute abdomen. Stomach's distended, gallbladder's distended. What's going on? Well, you scan a little bit lower, there's dilated bowel, and there's the reason. There's a hernia in the left lower quadrant. You can see what looks like a little knuckle there. You can see on the coronal view the dilated bowel, the transition in the left lower quadrant. You can see it on the cinematic. There it is right there. So what are we dealing with? We're dealing with bowel obstruction due to a hernia, okay? But I need you to define the hernia. And I know you would have said Spigelian hernia. That's what it looks like, right? A Spigelian hernia is a rare ventral hernia, which is defined as herniation of abdominal content or peritoneum through a defect, namely the Spigelian fascia, which is composed of the transversus abdominis and the internal oblique aponeurosis. It presents as a painful or painless bulge, particularly when standing. Typically, you get the feeling you could reduce it at bedside, but at the end of the day, these patients will need to be operated on. Okay, what else? Chest pain. I'll give you two cases. Cystic lesion, middle posterior mediastinum. Water density, displacing structures. You can think about malignancy, but it's water density and displacing. When you see water density, I'm thinking about cyst, duplication cyst, neuroenteric cyst, esophageal, bronchogenic cyst. Bronchogenic is the winner. Water density, they can be large. Bronchogenic cysts are typically in the paratracheal space and subcarinal. This was very subcarinal, but very large. Another patient, similar, cough, large mass, subcarinal region, water density, eccentric. Same differential, diagnosis, bronchogenic cyst. Gave you 2 in a row, okay? What about this pancreas? Large mass head of pancreas, lots of peripheral enhancement, looks somewhat cystic. There's no dilated duct in the liver or the pancreas. So that's not going to be a pancreatic adenocarcinoma in all likelihood. You can see the vessel drapes around the mass, and you can see the portal vein and SMV are displaced, but they're not invaded. If this was a cancer, you'd see duct dilatation, you see invasion. You could think about a GIST tumor perhaps, maybe it's not pancreatic. But this was pancreatic, and that draping is a classic sign for a serous cyst adenoma. Serous cyst adenomas can look like they're very vascular around the edges because of stretching of the vessels. The cystic sunburst pattern is really, really good for the diagnosis. What about this case? Body and tail cystic lesion with calcifications, but you see it looks like multiple cysts. You could say, well, could this be a SPEN in a young patient? Possibly. But there's no real solid component. Could this be an MCN? MCNs are in body and tail, 40-ish-year-old females, but typically it has septations, it has a wall, it's not so many cysts. Both SPEN and MCN can have calcifications, so that would be a thought, but lots of calcifications, particularly in that distribution. You got to be thinking, again, of one of the many types of serous cyst adenoma. What a great case. Now here I'm just showing another cystic lesion. It has a thickened wall, same location as the last case, but thickened wall, junction, body and tail of pancreas, 40-ish-year-old female. The thing you got to consider, number one, MCN, mucinous cystic neoplasm. Yes, I could have considered SPEN, but SPEN has more solid components, more calcification, but it could be. It's not metastatic. It's not going to be an adenocarcinoma. This was an MCN. Okay, we're getting near the end. Another cystic tumor, but there's nodularity. This could be an MCN, surely, with high-grade dysplasia. That's possible. Good location. And you see it again on these images, and you see it again in the coronal view. There's also some fibroids in the pelvis. So you know it's a female. It was a 32-year-old female. MCN's a bit older, but it could be. This was a SPEN tumor. These SPEN tumors usually are in teenage females, usually women, 9-to-1 over men, but they can be cystic and solid and can have a range of appearances, including having calcification. So that, I think, is 14 cases. That's a lot of cases in roughly 15 minutes. I hope you enjoyed those cases. I hope you got them right. I hope you listened to them. You can listen to them again. You can have a great time with them. But I'm telling you, I'm out of here. Have a great day, everybody. And as soon as I figure out how to stop this, I'm going to end the stream and see you later. I remembered after